Good evening, everyone. Thank you for joining us for the first Best Journal Club session of this year. My name is Dimitris Aloumas, and I am the fellow member of the BESS Education Committee. We are delighted to be joined tonight by the Edinburgh Shoulder team, who will be running tonight's session on shoulder trauma, with presentations of 3 papers and an editorial. Just a bit of housekeeping briefly. The session will be recorded. All the audience will be muted, but you will have opportunities to ask questions in the Q&A section, and these will be answered at the end of each paper. And we aim to finish at about 8 o'clock. I will now hand over to Mr. Jamie Nicholson, who will present tonight's presenters and panel and moderate the session.
Right, I'll just share my slides there, thanks. Right, hope that's up and running there. So good evening, and thanks again for the BESS committee for the invitation for the Edinburgh team to host this journal club. We've obviously had a long interest in upper limb trauma, largely thanks to Mike Robinson over the last sort of 25 to 30 years now. And we've got the upper limb team presenting tonight, Mike Robinson, Ian Brown, myself, Sam Mackenzie, and Andrew Duckworth. We've got 3 of our senior registrars who are kindly presenting for us, Andy, Rosie, and Kirsty. So we thought for the topic of shoulder trauma, we obviously still have a lot of contention around proximal humerus fractures. And for those of us with an interest and enthusiasm to manage these injuries, we still see lots of problems, both from the acute and the delayed sequelae of proximal humerus fractures. They're still contentious, and obviously, post the Proffer trial, we still have a lot of contention out there, particularly from some of our trauma colleagues, about the necessity and need to fix some of these fractures. And we're going to briefly discuss this editorial, which was just recently in the American JBJS, highlighting how the evidence would suggest we don't need to be operating on many of these fractures now. Now, I'll refer you back to one of Mike's papers from just over 10 years ago, which talks about this kind of spectrum of the injuries and skill set and patient personality and fracture patterns. And up in the very top right, you've got these clear indications for surgery, which would never make it to the trials. And then it's these relative indications that I guess cause a lot of the contention, which often probably don't go into the trials because we maybe don't have equipoise, or maybe we do for a certain extent. And I think these are the bits that we were going to try and tease out with the first paper, and particularly the risk of non-union and how to predict non-union of the proximal humerus, I think often gets overlooked when we talk about trying to pick out patients who will do maximally well with surgery. And then a little bit, probably in lesser hierarchy, certainly in my head, in terms of the benefit of surgery, looking at the role of function for proximal humerus fractures, and then we'll touch a little bit about AVN, hopefully, in our discussion. So we're going to talk about these 3 areas. Firstly, the non-union prediction with one of Mike's really influential papers, certainly in my practice, from the last few years, and then looking at predicting potentially who you'd pick for fixed versus arthroplasty if you've made that decision, and then finally on some of the adjuncts to ORIF, such as the modern trend to use calcar strut grafts. So we're going to start with Andy Ablett, who's going to look at this paper for us. Thanks, Andy. I'll just drive the slides for you.
Yes, thank you very much. Thanks for having me this evening. So, this evening we'll speak with you about one of the Edinburgh Trauma Unit papers regarding prediction of non-optimally managed proximal humerus non-union fractures. Next slide, please. So just despite the fact that these are the 3rd most common appendicular fracture, we still have poor understanding of not only the prevalence but also the risk factors associated with these with fracture non-unions. Despite there being a number of classification systems out there which do have their uses, they do not describe the morphology which is associated with fracture non-unions. And therefore, the authors set out to identify the true prevalence, but also create a prediction tool which allows early recognition of fracture non-unions. Next slide, please. So it's a single center retrospective study of 2,230 patients between 2002 and 2007, including all adult patients with proximal humerus fractures managed non-operatively. Importantly, they excluded patients with isolated tuberosity fractures, but also fracture dislocations. Um, Non-unions were defined at 24 weeks post-injury, both clinically and radiographically. And radiographs were assessed by a senior co-author and who was blinded to the outcome of the study. Next slide, please. Following linearity testing, it was found that fractures with greater than 140 degrees head shaft angle, so valgus fractures, acted differently from neutral and varus fractures, and therefore a decision was made to divide these and analyze this group separately. Following backward stepwise multivariate logistic regression, covariates were identified to be used in this model. And this model was validated not only internally, but also externally. Next slide, please. So one of the key findings from this study is that non-union of proximal humerus fractures 10.4%, which is actually far greater than many other previous studies. Another key finding is that fractures in valgus with a head shaft angle of greater than 140 degrees had a very low non-union rate of less than 1%, which is in contrast with those with neutral or varus who had a non-union rate of 12.4%. And this group was used for the Farron prediction model. Next, please. So the three key covariates they identified were head shaft angle, head shaft translation, and smoking status. Now, if you look at the table below, this is the snippet of the full risk stratification. But what they found was that patients with a head shaft angle greater than 90 degrees, less than 50 degrees of 50% head shaft translation, had very low rates of non-union, even in smokers. But once the head shaft angle was less than 90 degrees and there was significant translation, the non-union rates were 83.7% and vastly increased in smokers. Next, please. So the strengths of the study include the large cohort, the rigorous statistical methodology, and also the use of external validation. But there are some limitations that we acknowledge, including the single center nature of this, with 97% being Caucasian. And interestingly as well, there were 33 outliers with an unexpected non-union. Next, please. So take-home messages are non-union rate is 10.4%, greater than many previous papers. Valgus fractures have a very low non-union rate. The Farron study offers clinicians, offers us really, opportunity to counsel patients in clinic as a counselling tool to help patients come to a balanced decision. And interestingly, 76 of these non-unions occurred in simple near part 2 fractures. Thank you.
Great, Andy. So I'm going to come back to Mike in a second because obviously Mike was in Spacious paper, and I think this paper certainly heavily influences probably the vast majority of the proximal humerus fractures, certainly locally that we tend to focus with fixation. And I think it reflects sort of a wider body of evidence that the Edinburgh team have put together over the last few years, particularly looking at the role to predict clavicle non-union. And then some of the more recent role looking at humeral shaft fracture evidence with the recent RCT and potentially looking at some of the factors to tease out for the early non-union prediction of humeral shaft fractures. So I guess in terms of the highlights, I think as Andy's taken from this paper, the progressive or the varus at presentation combined with head shaft displacement is a key risk factor for non-union. And I don't know, I was going to go to Mike and Sam, but certainly my experience, and I think what's reflected is that non-union of the proximal humerus is usually quite poorly tolerated. And in terms of, I don't know if we have a feel, Mike or Sam, what you kind of, even for lower demand patients, how often this is quite an objective outcome of morbidity and misery for patients.
Yeah, I think that's certainly true. You mentioned the clavicle study. I mean, I grew up basically with this belief that all fractures healed, and this was carried forward through to proximal humeral fractures for a long time. I think with both of those injuries now, it's kind of realised that the prevalence of non-union is much higher than was previously reported historically. So it's about 1 in 10 patients, and really it's an injury that's a complication that once it develops, it is really poorly tolerated. A lot of the patients do have persistent pain, flail shoulder, and not much function in the affected arm. So really that was the purpose of the study, was to try and tease out some of the risk factors and identify maybe the 20% of patients who are increased risk of this complication.
And Mike, how much emphasis, obviously this study came out of X-rays at the time of presentation, but how much do you think we kind of change our prediction of that non-union based over the first 2 to 3 weeks in terms of progressive varus collapse or that head shaft translation? How often do you think that's dynamic, or it's actually there from the first presentation X-ray of the first week?
I think the translation often remains the same, but what sometimes does change, there are early indicators, certainly if you look at patients at about 4 to 6 weeks of that non-union is developing, the scalloping of the head caused by movement of the fracture site and the progressive varus. All these are indicators that non-union is more likely, but a lot of the risk factors really are there at the outset. And it is, most of the non-unions probably are reasonably well predictable, but there are still a few unexpected non-unions which are more difficult to predict because they are based upon specific comorbidities or idiosyncratic things that occur in individual patients, which you can't really easily factor into a more generalizable model.
Super. And obviously you wanted to highlight that editorial paper, and I wasn't sure if you wanted to make a few comments on that. I know we briefly discussed some of the slight risk with some of these slightly underpowered studies where there's a collection of minimally displaced 2, 3, 4-part fractures, which often have equipoise when we see these in our trauma meetings and in our fracture clinics, and whether that's a fair reflection of some of these more difficult fractures that we encounter.
Yeah, I mean, I think the editorial is very useful because it's got that dialogue going. Again, I think probably there has been an overuse of fixation, probably in centres based upon poor indications, poor patient selection, and unsurprisingly, the results of the trials as a result have failed to demonstrate any benefits from that. The problem we face day to day in clinics is that we still see people with non-unions, and it's really hard on day one to justify adopting a blanket approach, which is being suggested in the editorial, of just saying, well, surgery isn't justified, so therefore we're just not going to operate on any of these patients. I think that was really why I thought it was useful to include that editorial, because it has got that debate open again. When I was a trainee, this was kind of the approach that was adopted. There was this belief that they all heal, so just leave all the fractures and just deal with the secondary complications. But that's probably shortchanging a lot of patients as a result.
And I guess open to Mike and Sam, in terms of, we manage a lot of clavicle and humeral shaft non-unions, and I'd say certainly our own experience of those and what's reflected in the literature is that can be a slightly challenging operation, but generally an operation with not a huge amount of morbidity attached to it. I think the overall rate of a recalcific non-union from humeruses and clavicles is about 5% of the literature, maybe a little bit higher in smokers, but I don't know if we have. I think it's certainly a very different operation for established non-union of a proximal humerus fracture, and often in my hands it ends up as a sort of salvage reverse, unless obviously the patient's much younger. What's your thoughts about that, Sam?
Well, I think this paper came at a great time for me to start in practice. I've been year 6 now, and I was privy to some of the results because the other author, Ewan, was a flatmate of mine when we trained. And I think trying to avoid non-union is how I've tried to go forward with things. And that's mainly been through chatting with Mike and reading his research. And there's lots of things that he's done to help us identify those patients, not just on x-rays, but also assessing of soft tissues, skin puckering, anterior bruising. They're all important factors. But I would find that the non-union of the proximal humerus, particularly one where the medial, the proximal segment is diminished, so there may be intact tuberosities, but there's very little lateral column bone, or if there's significant loss of the calcar, so the classic scalloping, that would be one of the hardest operations I do. and one of the hardest things to have success with. So I think the morbidity of the secondary intervention is higher than it would be for the shaft or the medial or the clavicle. So yeah, I think I agree, Jim. I think they're the hardest thing to do. So I try and avoid that at best costs and at all costs if I can by intervening a bit earlier. But I would say that we generally still have an appropriate intervention rate. I don't think we over intervene, but one of the things I was going to ask Mike to comment on was using the modified axial view, and obviously that's the best possible view at the time. But then translation can be undersold if the angle's at a particular trajectory in the plane of the fracture. And Mike's got sometimes some tips for watching out for that, or what to do with it.
Yeah, making the films standardized is useful, but also these days I think CT is becoming increasingly useful in the assessment of these injuries. So that's becoming sort of that's probably a separate discussion, but I think certainly that's helpful as well. One of the things I think that a couple of things really. The paper later on, which we haven't really touched upon, deals with the thresholds for when you should be considering surgery for, and that obviously varies depending on your threshold of risk based upon the 3 factors which were significant. The problem with this that's not dealt with in the paper is that the people who are highest risk are probably the people you least want to operate on. So the patient with a completely displaced fracture, frail, elderly with and heavy smoker. These are the patients that you really don't want to operate on, but probably stand the most to gain if you can prevent them developing the non-union. But it is high risk surgery. There's no doubt about that.
And just before we wrap up and take if there's any questions from the audience or any of the panelist questions, just because we don't necessarily come back to this. So I still struggle in my head what to do about the AVN prediction. I know this is a slightly different topic, but just when these outcomes, a very binary outcome of AVN or non-union, do you think we're any further forward with trying to pick out which patients will get AVN despite intervention and are potentially ones for either an early or late arthroplasty versus those where we potentially can alter that natural history with an early ORF, and obviously looking particularly in the non-arthroplasty population during these medial calcar separations with a very skeletalized anatomic head in the under 50s in particular. I don't know, are we any further forward with that, Mike, from Hertel's paper 20 years ago in terms, I know you're not a huge fan of that in terms of the accuracy of it. We've chatted about it before, but
I mean, I think there's some fractures that definitely almost certainly doomed to developing AVM. But I don't think that early fixation necessarily alters that risk particularly. I think if you operate on a patient with a 4-part valgus fracture or separated medial calcar, if you follow those patients through for long enough, almost all the surviving patients will eventually develop AVN if they've been treated non-operatively or if they've been treated with fixation. So I think that's one situation where the indications for surgery are much more woolly. With non-union, it's much more clear-cut, but I think operating to try to prevent non-union, particularly with a head salvaging procedure, is a soft indication, I would say.
Excellent. Any other comments from the other best colleagues who are with us from the panel, or any other questions just before we move on to?
Could I just ask a quick question about this paper, Mike? Why do you think you found a higher incidence of non-union in your cohort?
I think it's basically to do with follow-up and adequate follow-up over time. I think that some epidemiological studies, particularly there was a study done in Edinburgh in the mid-90s which quoted a similar low non-union incidence. But I think if you look at the actual follow-up in those patients, it is difficult sustaining follow-up in smaller groups of patients. And I think if you're following the patients that rigidly and using rigid criteria for non-union, the prevalence is high. I think for all of these injuries, it always seems to come in at around a 10% incidence, and I don't think the proximal humerus is any different with regards to that. I think it's just that longitudinal studies are thin on the ground, that have looked at this complication with non-operative treatment. And I'm not sure whether the prevalence is getting commoner, possibly with the aging population and lifestyle-related issues and comorbidities. But I think 10% was sort of the figure that I had in mind, even before this study was done, in terms of what the actual prevalence of this complication is. So I think it's realistic.
Thank you.
Any other questions, Dimitris, just on this topic before we move on? Or Sam, have any other comments?
I think there is a question in the Q&A section, Jamie. It says the incidence of proximal humerus fracture is rising. Is there a similar rise in non-union rates?
Do you want me to answer that? Yeah, it's difficult to say. I think that it would be interesting to repeat the study, say, and look at historical data, but it's difficult to be certain. I would imagine probably the prevalence is increasing because people are living longer. Certainly, age is likely to be a factor, and also elderly patients are more likely to be comorbid. So you would imagine that the prevalence is the relative prevalence is increasing, but it's not known. That there's no real answer to that at the moment.
It's certainly reflected in the humeral shaft papers, and our colleagues Andrew Duckworth and a few of the team did a recent BJJ paper about the changing epidemiology of humeral shafts, and that's essentially a geriatric fracture, like a lot of the upper limb fractures that we deal with now. And it's interesting how much that demographic has changed as well.
Can I just ask quickly as well? I know, Mr. Robinson, you said CTing is a completely separate topic, and I agree it is. But certainly in the continent and maybe in the States, they are a bit more liberal CTing these fractures even early. Do you think CTing can help predict non-union a bit more reliably compared to X-rays initially?
Yes, is the short answer. We've actually got a study that's in print shortly, which is really a follow-up study to this article, which examines the CT findings in a fairly large series of patients. And certainly, if you subclassify the injuries and look in a more detailed way at things that can't be assessed quite so well with plain radiographs, such as displacement translation, then it does give you a more precise estimate. And we certainly use it very widely in pretty much all the displaced fractures in patients who would be considered for surgery.
Super. Well, we'll look forward to that. It's coming out shortly, BJJ, I think, Mike, isn't it? Look. So if that's okay, just wary of time, and obviously we'll continue the discussion next paper. We've got one of our senior trainees, Rosie Hackney, who's fresh off passing the FRCS, who's going to tell us a little bit about patient selection for fixation versus arthroplasty. So this idea of the deltoid tuberosity index has been around for a few years, and there's a recent paper in the American Journal that we're just going to discuss briefly. Thanks, Rosie.
Good evening. Thanks very much for the opportunity to speak this evening. So the paper that I'm discussing this evening evaluates the deltoid tuberosity index, or the DTI, and whether it's a useful, simple radiographic marker of systemic osteoporosis in patients presenting with proximal humerus fracture. So the study is a retrospective cohort study in a single center in Asia, with the majority of patients being of Chinese origin. The aim of the study was to answer two questions. So firstly, is use of the deltoid tuberosity index reliable and reproducible as a measurement? And secondly, does DTI correlate with the WHO DEXA-defined osteoporosis in an Asian population? And so the group collected 149 proximal humerus fractures and excluded patients based on cognitive impairment, but mainly whether or not they'd had a DEXA within the past year. And so they end up reviewing the imaging of 87 patients, and they performed the DTI scoring by 4 scorers. So there was a consultant, an orthopedic registrar or resident, as they call it, and 2 senior medical students. And the imaging was then repeatedly reviewed in order to observe whether or not there's any inter or intra observer reliability. And they repeated the observations at 2 weeks. They looked at whether or not there was inter and intra observer reliability using a two-way mixed model ANOVA and Pearson correlation coefficient, respectively. And so what they found is that there was very good inter and intra observer reliability, including between the consultant and the medical students, suggesting this is a very simple, easily utilizable method of measuring bone density in our clinics. They found that DTI had poor to moderate correlation with DEXA bone mineral density measurements, and they classified DTI of less than 1.6 as a reasonable diagnostic threshold of systemic osteoporosis, which does differ from some other literature, which would quote 1.4 as the cutoff. So the strengths of the study are that they demonstrated that this is a quick and very easy test, and it's reliably reproducible even by junior members of a team. And given that, the authors then would propose that DTI can be used in clinic as a bit of an opportunistic screening tool that can be derived just from standard shoulder radiographs without any additional imaging, such as the CT scans in the literature, or any additional cost. And there is some research to support using DTI in order to gain a little bit more knowledge about bone density in the proximal humerus, so you can plan the use of augments versus arthroplasty. But further correlation and validation of surgical outcomes and DTI would be required in order to really make that link. The limitations of the study: it is retrospective, it is limited to an Asian population. And its limitation really for me would be that the patients are excluded if they don't have a DEXA scan. So we've collected patients who have had proximal humerus fractures, patients who have had DEXA scans, which in the UK population, if you consider that, if a patient's got a proximal humerus fracture and has had a DEXA, they probably fall into the category of having low or abnormal bone mineral density. I'm not aware in the population that in the paper what threshold there is to obtain a DEXA scan in that population, but certainly in the UK that would provide some selection bias. So in summary, they found that we've got a quick, reliable, reproducible test that shows moderate correlation between bone mineral density. And so just thinking about kind of take-home messages and considerations that I have as an orthopedic registrar interested in upper limb. So can we reliably utilize the DTI in the outpatient clinic to consider whether or not our patients need onward referral for bone mineral density, so DEXA scans, and eventual referral for input in terms of metabolic bone management? And secondly, when we're seeing our patients in clinic, can we reliably utilize DTI in our operative planning and decision making about fixing versus replacing augmentation strategies? So some papers, as I've said, would suggest 1.4 would be a cutoff for low bone mineral density being a risk factor for displacement in conservatively managed fractures. But it's not clear really from the literature, and particularly this paper, whether the 1.6 or 1.4 cutoff would be able to be guiding our surgical practice as a whole. Thanks very much.
That's super, Rosie. Thank you. So Rosie's alluding to there that this paper really, Jim, it's been around in literature for about 10 years now, this DTI index, and there was a little bit of concern about how accurate it was and how reliable it was. So it's kind of shown twofold that it does correlate quite closely with the DEXA, and it does seem to be reproducible. I guess what we're kind of lacking is how useful a prognostic marker it is in terms of predicting the risk of fixation failure. And I certainly couldn't find too much out there in terms of solid prospective evidence which kind of justifies it as a selection tool. We do have to admit, tend to use it too routinely in Edinburgh. We've chatted about it a few times, and one of Mike's other recent big papers looked at the outcomes of a whole mix of kind of complex proximal humerus fractures which underwent ORF, and the risk factors from that study were for failed of or cut out of failure fixation was smoking, comorbidities, tuberosity involvement, head shaft disengagement. So as you'd expect, the more complex type fractures. And then there's been a little bit of evidence about looking at the kind of Hounsfield units on CT, which I guess ties back into this DTI. So in terms of where we're at with the use of DTI, I'd be interested to hear what Sam and Mike think are the best panelists on whether it's something that you actively look at or comment on in the clinic in terms of if you've decided that someone needs intervention for severe head shaft or severe tuberosity or non-union risk, then and how much does that go into your decision making? Or is it mainly age and comorbidities, which I think it often is in my head, and the complexity of the fracture for ORIF versus reverse? I could start with Sam, perhaps.
I think I'll let Mike start off actually, and I'll go after him because Michael, if you Mike's the brains of the operation, I'll add in a little bit afterwards, perhaps.
Well, yeah. It's not something I've ever used before. I think it's a very interesting concept. I think it is part. It certainly adds to the overall picture of this sort of group of patients with more severe fractures, displacement, who are more osteoporotic. And I think as tied the studies you had on the previous slide there alluded to the fact that these with the limited, albeit that those studies were slightly flawed. It's actually the one after that, I think. This one to the. I'm just trying to, risk factors for fail fixation. Sorry, it was the previous slide actually, but yeah, the people have tried to correlate these findings with. This was a study here, De Silva, wasn't it, and Spross as well. They've tried to tie it in with the risk of fixation failure. It harks back to what I was saying earlier, that the patients who are at risk of the complications from surgery are this group of individuals in whom exactly you don't want to operate on, the smokers who tend to have this thinner cortices and a risk for fixation. So perhaps it tilts you more towards using a non-head salvaging reconstruction when you're thinking about the surgery, but I think it would be just one of many factors that you would take into consideration when you're counselling the patient about this.
So I think I agree. I think by definition, where we are, if you have a proximal humerus fracture, then you're referred for DEXA, and the rate of pickup of osteoporosis is high. So the DTI is useful, but it's already in our mind, and we're used to fixing thin, poor quality bones. So I would say head volume and tuberosity involvement would be more of something that would make me worry about whether somebody would be suitable for fixation or primary fixation with or without a graft. So I think it's a nice paper to consider. But also, I think standard radiographs are different. There's some papers looking at CT measurement, which would be easier to round out and be more confident that my radiograph's not 15 degrees more internally rotated than your radiograph. So I think the CT version would be something I would be more interested in using going forward. But we wouldn't have that in all patients, but we'd have it in all patients that were being considered for surgery. That would be something we would routinely do. So I think it's helpful, but it wouldn't change what I would do too much.
There are a wide range of other modalities that are available. You did alluded to using Hansfield units on the CT. Certainly been used. The more generally used one is the Tingart and Wartner's thing, just using measuring cortical thickness. It was interesting to see that in this study that the inter-observer variation was fairly good. It is a fairly precise measurement that you have to make there, and the location of the deltoid tuberosity isn't always included on our films in any case. And location of that is somewhat nebulous, and I must admit I'm not certain my reliability in making those measurements would be as good as the authors, but maybe it's my failing eyesight rather than their scientific rigor.
Yeah, I had a couple of goes. I definitely had the mist spray and the glasses cleaner out when I was trying to do that, and I wasn't as convinced as the paper suggested.
Excellent.
I think basing your treatment completely on that. I think the message is it's useful, but it's not necessarily a deal breaker in terms of guiding your treatment. That's what I would say from that.
So on that note, Mike, have you changed at all in terms of your threshold for arthroplasty versus fixation, in terms of if you've got a two-part off-ended fracture in a reasonably fit and well 8-year-old, you still consider the potentially less morbidity with ORIF versus arthroplasty versus that small risk of, depending on what you look at, do you mean 10 to 20% fixation failure, or what's your kind of threshold now? Is it mainly on your CT findings, or?
Things have changed a little bit. We are getting to these fractures a little bit later now, and that does definitely influence the decision making. That certainly is a factor with the triaging clinics that we have at present. I'd still go for fixation by and large in a fresh fracture if there's no tuberosity involvement, because I think it gives you the chance of. That's probably the best single indication is the two-part fracture in a patient with separation and intact tuberosities for fixation. But certainly, if the bone was very porotic, certainly removing that issue of persistent non-union despite fixation or fixation failure from the equation. I think you may be a little bit pessimistic with the overall fixation failure rate. I think overall, again, it's about 10% of patients in whom you use primary fixation where things would go wrong. About 5% of those would be patients developing late AVN, and about another 5% where you get early fixation failure. That's at least in our unit based upon our findings. But there's no doubt that the advent of reverse arthroplasty has made that operation a better intervention than it was, say, 10, 15 years ago when we were more widely using hemiarthroplasty, which didn't seem to produce such good results.
Perfect.
I don't know what about that.
Yeah, keen to hear what the best minimums think about that. Any other comments from the chat? Yeah, thanks.
Yeah, no, I think Sam and Mike have summed it up quite nicely. I mean, for me personally, I'm aware of it, but I don't think in a busy fracture clinic, it's very difficult to start measuring those things on your pack screen. And while preparing for a presentation, I came across this index, and then I made it a point to look out for this index. But again, as Mike said, the X-rays that we get in our fracture clinic don't include that tuberosity area. So it's not that often that you can actually use this technique to do the measurement.
Yeah.
So whether you consider using this index as a tool to guide your fixation on the one hand, or whether you just use it as a measure of supplementing bone health, I think that's probably the question, because the paper is more, the implications of the paper are towards diagnosis of bone health and supplementing bone health rather than supplementing or guiding your fixation technique, I think.
Yes, I agree with that. That's very precisely put, and that sums it up nicely.
Great. Well, there's any other questions, Dimitris, from the chat? Just there's an opportunity there just before we go into the last paper, because I think this is last one's obviously a good one for discussion as well.
Yeah, there's two questions actually that just came in. The first one is, are complication rates of ORIF and reverse shoulder replacement similar?
We defer to Mike for that.
It's a different set of complications. Fix it. The concern you always have is late AVN and so early fixation failure and late AVN, and overall, at least in our hands, the risk of that in that study that you showed earlier was about 10% overall. With reverse, it's still early days in terms of the long-term outcomes from the use of reverse, but certainly it removes that 5% risk of early fixation failure. But you do have a new set of complications. Some patients that I see certainly have persistent pain, which is difficult to pin down. You think about low-grade infection, things like that. Chromial stress fracture is suspected. So I'm not certain in my own mind that the better looking x-rays that we see with the reverse, avoiding the high riding humeral head, necessarily translates into massively improved functional outcomes for these patients. But I'd say in terms of the complication rates, probably not dissimilar overall between the two groups of patients. But the main advantage, obviously, of using the reverse is you are hopefully just giving the patient the one operation, whereas with fixation, if things go wrong, you do then face a pretty difficult revision procedure at a later date.
And the second question reads, if you do proceed to reverse for a displaced two-part, do you knock off GT and LT to repair around reverse or accept deltoid solely? I'm not sure what that's meant to say.
I think it's asking about whether you should fix the tuberosities or discard them. Certainly when I started doing these procedures 15, 20 years ago, the thinking at the time is you could just discard the tuberosities and that was it. And mostly at that stage, I was using the reverse for just salvage procedures. Increasingly now, we're using them more for acute fractures. And I would always attempt to osteotomize the tuberosities and repair them anatomically, because I think there is some evidence to suggest that certainly external rotation movement, active external rotation movement is preserved better if you do that, and that probably improves the patient's overall functional outcome in doing that. But I don't think that's necessarily proven by the literature. But that's just, I think, the way the current thinking is going. Would everybody else agree with that, Sam?
Yeah, absolutely. I think they fix them. I think when I first read about it as a trainee, somebody would make you think that a reverse could solve just about any problem in the shoulder, but rotational difficulties, so the inability to maintain even neutral without a tuberosity is a big problem. So I think it seems to be fixed by everyone really now, doesn't it? Both LT and GT, if possible.
There's still a bit of contention for the delayed reverses, and in the context of a severe malunion or non-union, if you can, as I see, I think the classic Pascal Ballot paper about whether there's a high rate of complications trying to repair your tuberosities if they've been kind of chronically short or in a malposition for a long period of time. And I don't know what others' thoughts are on that. I think if they're in the ballpark, I'll try and repair them like I would for an acute, but if they are severely short and going to cause issues, I would probably just excise them for the risk of impingement or issues.
Yeah, I think in the latter, I don't think you have much of a choice, really. I think you'll know often they won't have a sufficient excursion to actually go to a place and implant that would be appropriate. So I don't know if you really can have the choice in some of those very complex ones.
Yeah, I would agree. I think when that paper first came out, the main option was really sneaking in a hemi, and it's probably easier to do that without osteotomizing the tuberosities. And there was some evidence that improved the outcome, but I think if you're trying to put a reverse in, it's very difficult to avoid osteotomizing the tuberosities to really just to get the access and to do the procedure. So I think probably in most instances we'll be looking to detach the tuberosities with a malunion and then reattach them. It's just very difficult to do the procedure without that, at least in my hands. But what's your feeling, Jamie?
Yeah, they're the same. I think if the tuberosity is in a position where it would look sensible with the reverse, I'll try and keep it and treat it like a primary. But if it's short and round the back and we as you were saying, we certainly see patients with slightly unexplained pain at time with reverses, and I don't know. I feel kind of anecdotally when I've got a perfect looking X-ray for the first few weeks after a fracture reverse, I often feel that they are some of the most unhappy patients for the first month or two for the stiffness, rather than when there's little tuberosity to repair. With potentially some of the more severe elderly fractures, then I don't know if there's a degree of increased stiffness that we buy, obviously, for that long-term functional gain for the external rotation, as you say. But I'm certainly wary of that in some of these salvage delayed ones, of particularly of impingement risk for the risk of dislocation, because I know there's a slightly higher complication portfolio with salvage reverses in the delayed kind of non-union or severe AVN and malunited tuberosity setting. So I'm very wary of anything that might raise that risk of dislocation. It'll go in the bin.
Yeah.
Okay, just for the sake of time, I wonder if we should go on to the last paper, just talking about adjuncts to ORF. So this is a RCT that one of our senior trainees, Kirsty, is going to present for us. Thanks, Kirsty.
Good evening. Thank you very much for allowing me the opportunity to present. And today I'm presenting the 2023 randomized controlled trial from the Journal of Bone and Joint Surgery by Wang and colleagues. It looks at and asks the question, does adding a fibula allograft to a locking plate improve outcomes in proximal humerus fractures with medial column comminution? And they start off by establishing the rationale. Medial comminution compromises the calcar, leading to varus collapse, screw cutout, and fixation failure. And the fibula allograft is inserted to restore medial support. Before moving on to sort of discuss the study in detail, the headline result really is there's no significant difference between the two groups in any outcome, the functional scores, the pain, the range of motion, or the radiographic maintenance, the neck shaft angle and complication rates. Although both groups did improve over 24 months, which wasn't the primary outcome, and screw penetration rates were similar. So just to go over the study design, it was a single center randomized controlled trial conducted at the Shanghai Jiangsu University Hospital between 2016 and 2019. 754 patients were screened and ultimately 80 were randomized, 39 to receive fibula allograft and 41 to locking plate only. And they followed them up for 24 months, although, as I've explained, the primary outcome was the DASH score at 12 months. Both groups were operated on by two surgeons, experienced surgeons, using the Phelos plate, using the delta pectoral approach. And it is worth noticing, and I think this is probably one of the weaknesses of the trial, that cancellous bone grafting was permitted in both groups. They had an inclusion criteria of adults with medial column comminution greater than 3 fragments acute fracture, with fixation being indicated. Their primary outcome measure was a DASH at 12 months, but they also recorded secondary outcome measures, the DASH at other time points, VAS pain score, range of motion, patient satisfaction complications, neck shaft angle, and humeral head height changes. With regards to the patient demographic, it's the patient demographic that's been discussed tonight and recognised to us all. The mean age was 60, although they did include adults over 18, predominantly female, low energy falls. With regards to the key outcome, there's no significant difference at any outcome between the two groups, although groups did improve over the 24 months given the outcomes. The radiographic outcomes, the neck shaft angle, humeral head height, were similar between two groups, and they did show a trend towards varus over time. A subgroup analysis was conducted below 65 and above 65, which showed no substantial benefit from fibula allograft. And it also showed the fracture healing rates were high in both groups, and both these radiographs were assessed throughout the study period. Moving on to discuss the strengths and weaknesses of the study, it is a step forward from the retrospective observational data that's preceded it, and the trial features blinding of the outcome assessor and the data analysis. There was no crossover of arms, and although there was a high follow-up rate to the primary endpoint at 12 months, that follow-up did decrease to at 24 months, it's only 50%. The study, however, it was underpowered. They downgraded their power assumption from 90% to 80% mid-recruitment. And as I alluded to previously, I think an important factor was the fact that cancellous bone graft was permitted in both groups, and it was used in around a third of patients in each arm, which arguably could have compensated for the absent medial support in the locking plate only group, so could potentially narrow any difference between those groups. I think overall it's an important trial, but the findings should inform rather than definitively change practice. And there are some more recent papers which have contradicted their finding. Desari et al. In 2022, which is actually cited in the paper's discussion, was meta-analysis of 10 studies. and 802 patients, which found significant differences favouring fibular allograft augmentation, but their outcome measures were humeral head height, neck shaft angle, and they also found that the odds of developing a major complication with an odds ratio of 0.37 in the fibular allograft group. Another paper that's also discussed in Wang et al.'s paper is longer from 2024, which was augmented versus non-augmented lock and fixation in proximal humeral fractures, a systemic review of meta-analysis. It includes both cement and bone graft augmentation and found no statistical difference between the augmented and non-augmented cohorts, with DASH scores as well being used. So I think, to sum it up, the bottom line is a well-conducted, clinically important randomized control trial that at the time was the first. It provides level 2 evidence that fibular allograft augmentation does not improve functional outcome or radiographic outcomes over lock and plates alone with medial column comminuted proximal humeral fractures. However, there are some weaknesses to the trial that should be set in context when taking in part of the results.
Perfect, Kirsty, thank you. So I thought you raised a good point there, that the powering is kind of one of the big issues I had with this paper, and the fact it was powered to the DASH score and not powered to complications, which would have been, in my head, the more theoretical thing that we're interested in, with the role of strut grafts, particularly in the medial comminuted varus off-ended fracture in the elderly, which probably is our main indication, and our role of these strut grafts over the last few years, certainly in our department. And I thought it was interesting that it was only about 1 in 4 fractures from the trial were 2-part, and majority were 3 and 4-part, and that probably explains the role of bone grafting, which in my interpretation was probably for the valgus fracture, where they raised the head and then put some impacted cancellous bone graft behind it. And I'm not sure, we don't tend to see the morbidity or the non-union rate with those fractures, because the natural history of them tends to be better anyway. I was interested to hear Mike's thoughts and Sam's thoughts on this paper, and how it reflects our own practice and using these calcar grafts probably over the last 5 years or so, I would have thought. Is that right, Sam, Mike?
Sam, do you want to comment? Or
yeah, well, I think we do it. Just going back to the paper before I comment there, I think it's important to note that the actual definition of medial comminution here was 2 or 3 fracture fragments at the medial calcar. So I don't know what that means really. That various fractures, valgus fractures, as Jamie says. So I feel it's a very heterogeneous population. And I also think a slight issue with the paper is just a lack of quantification of the fractures in terms of their morphology, rather, but also the rates of non-union were the same on both sides. And we've already talked about that probably the biggest predictor of a good outcome is will it heal or not. And I think in this group, trying to work out if a graph will help it heal or not hasn't been defined. And the quick dash is an outcome in an upland trial pretty much always gives us 80 people. That's sufficient, and that's why people use that to power, because these are very hard things to do. But for the granular detail we require, I feel the paper is lacking. Also, they have sort of quantified their reductions and whatnot, but we haven't really had good information about the plate position, calcar screw in the bottom third of the head, and it just lacks the kind of things that you'd want to know, I think, and they've used a straight graft, a fibular allograft, so that's a bit different than what Mike has been doing in Edinburgh.
Yeah, I would agree with all that as well. I mean, I think if you're setting up a study to look at a mechanical construct and having the DASH score as the primary outcome measure, that's a big mistake, because you're not going to show. There's never going to be a difference between that. And we've alluded to the power of the study. I think another thing which ties in with a lot of the studies quoted in the Brawson review article as well is that one of the things that the statisticians now like us to look at with negative findings is the fragility of the findings. So if you look at this study, how many patients would it take to flip in terms of their outcomes from one side to the other to make the negative finding into a positive finding? And I think just doing a brief look at that, you probably about 2 or 3 patients needed to flipped in terms of their outcome for the findings to be completely different. So the reverse fragility index of this study is also fairly poor as well. So like a lot of the studies that are quoted in the review article by Brawson, the findings are somewhat suspect, and I don't think from that point of view you can really draw a huge amount of conclusions based upon their primary outcomes. And so I would say that I'd be more. I certainly wouldn't give up on the use of this technique based upon the findings of this study. I think it's still quite a useful technique definitely with the right indication. I think the problem with, like you say, the classification of these injuries is that there isn't really a good classification that would include the factors which are important. The involvement of the medial column is difficult to quantify, and that's led to probably, as you say, the inclusion of patients who probably were inappropriate for a study of this type as well. So all in all, I wouldn't. I think, Jamie, you've had more luck using double plating for these type of fractures. Is that something?
I was just going to highlight briefly, because I guess that's kind of two main adjuncts that we tend to use in terms of. I was just going to mention briefly there, sorry, about the importance of the reduction, importance of the adequate kickstand and Calcar support, which, if you're not familiar with these papers, is obviously critical for success with the proximal humerus fractures. And I've had less experience with the Calcar strut grafting, really because of a combination of fellowship and kind of early consultant practice. But I certainly have a lower threshold for an adjunct plate, and there's a couple of good papers in a technique paper in the GOT showing how you can get pretty good orthogonal fixation, and you don't have to go super anterior, super around the corner immediately. There's one paper about almost taking down the lat dorsi and doing like a kickstand plate right on the medial column and putting them in a throwing position to put that plate on at the end of the case, which I think is a wee bit extreme. But using particularly a third tubular locking plate upside down in the bicipital groove works perfectly, and particularly for these apex anterior very unstable fractures where it can be quite challenging to hold your reduction, and you've got wires, you've got your cuff sutures, you've got a DHS guide wire pin joysticking into the glenoid, and all the tricks you can trying to get your Philos plate or whatever your proximal locking plate of choice is in a perfect position can be quite challenging with about 3 assistants there. So I find having a little third tubular locking plate in my bicipital groove will particularly reduce that apex anterior deformity, and then you can usually fit it around your Calcar screws. I found that to be very helpful.
I think it's
Here's a question.
Isn't it? Using the anterior plate, it does get around a lot of the problems because you can get the provisional fixation of the anterior plate to start with, and then you've got much more leeway then to put the lateral plate on just as a neutralization plate rather than the way around.
Yeah, and I would tend to just use 1 or 2 provisional screws deliberately out of the way of my kickstand screws so I can make sure they don't get in the way, and then anything I get after that is a bonus.
Just a quick question from the participants. Robin is asking, are changes in plates improving outcomes? Polaris plate with longer Calcar screws support head, reducing chance of superior perforation as an example.
Personally, I would say far too much attention has been devoted to the plate technology and really not enough to the actual techniques to achieve anatomic reduction, which is what we're looking for with these fractures. And I think the problem again is that the classifications, existing classifications, serve us poorly in terms of reading the anatomy of these injuries and the techniques that are required to reduce the fractures. So I wouldn't necessarily say that the plates have had a huge impact on the outcomes, but I think a greater appreciation of the anatomy of these fractures and being able to reduce them and use adjuvant techniques to stabilize the fractures, particularly thinking of the medial column fractures and the apex anterior fractures, that's where possibly the improvements in outcome will come in the future.
Would it be okay just to mention what we do just locally, Jamie? Have you got a moment? Just so
Yeah,
I know there's lots of people that do,
that.
fresh frozen fibulas. They do vascularized fibulas. Just when I came back from Australia, Mike was using fresh frozen femoral struts and fashioning almost like a hockey stick shape that would be slightly more bulbous and medialized in the head and then go down the shaft. And then we moved to actually a freeze-dried femoral strut for cost and storage implications. So it's easy to have one whenever you like. It probably doesn't offer any bioinductive assistance, but it's like an internal splint. And I think it's a really useful thing to have and use, and for any fracture that's more complex or if they're porotic. And once you have that in situ, it does take a degree of dissection to have access to place that large bit of bone. And some people may not be as comfortable with that or think that's a good idea. But what I've always been struck with is when you have a piece of bone inside that's working as an internal strut or a medial calcar support or reconstruction, the fracture stays reduced as you move the distal segment. You can rotate. It offers such inherent stability, and it's very reassuring before you again apply the plate. Almost like a not quite a neutralization plate, but I've been quite struck with how powerful those are. And I think we've got well over 100 and something now, Mike, haven't we? I think we're like 120 or 30 or more now of those.
Yes, yeah, that's
being written up
against the correct indication. I think in the States, a lot of other centres in Europe, it's been just used across the board, and then when it came to a lot of these being revised amongst the secondary reconstructive surgeons, they got a very bad press because trying to remove the strut if you get a persistent non-union or get AVN, it can be quite tricky and challenging. But I think it's because the indications were widened too far. But certainly with the correct indication in these sort of maybe 5-10% of fractures where you've got a varus fracture with loss of that medial support, fracturing of the medial support, then it's a really good indication.
What's your top tips in terms of keeping that calcar graft in the position you want whilst you're securing your fixation? What do you guys tend to do in terms of once you've got it in the position you want to keep it there? Do you use K-wires provisionally, or do you try and make it so it's a press fit so it doesn't migrate down the canal? Because I guess if it pistons down the canal before you've got it secured in place with screws around it, how do you keep it there?
The geometry, because it's a curved implant, the geometry often will secure it in position, but if it is unstable, you can hold it in place temporarily with K-wires. One of the technical difficulties with the techniques we have at the moment, which we've not perhaps fully ironed out yet, is then putting the screws in and around the graft, because quite often you find yourself drilling through the graft, which predisposes to fracture, and then you lose the effect of it. So that's something that is sometimes challenging, but you can usually just about get around that. But definitely the geometry of the hockey stick type configuration, once it's press fitted in, it's usually fairly secure and doesn't tend to move very well. But if it's unstable, you can secure it in place with a K-wire through the anterior cortex into the graft itself, and securing it in the.
I would say the most difficult ones are those with slightly that have got some bone left. If there's a capacious head, the graft can be stoved into almost a small fin-shaped divot in the head, so you can actually wedge it up and use a cocker lever in the lateral column to push the graft into the head and actually trying to make it grip in the head. And that's a capacious head, but in a more solid head, it can be difficult. And actually, the graft that's of what you might view as a normal size when you do this can cause displacement. So the younger patients with better bone, it's much harder to get that right actually. So you kind of want like an empty head, and it becomes like a volume filling component. And yeah, as Mike said, ideally you want the screws if you say use a Phelos plate to go around the graft. It's because it's unicortical, it's thin on the sagittal plane, but very wide on the coronal plane. So ideally the screws will go either side, and if you think about a Phelos plate or a EVOS plate, those calcar screws will hopefully wedge either side and not engage the graft because it's cortical bone and relatively thin in that sagittal plane. So
I think that one in the better bones is an interesting point, and we've chatted before about when you've got younger patients during high energy off-ended fractures and whether to accept a little bit of bayoneting of the fracture rather than quite a destructive approach potentially to try and get a calcar graft in and jacking the thing out and trying to get a calcar graft if there's not a huge amount of scalloping or bone loss in the head, and potentially where some of the adjuncts come in as an alternative, particularly for some of the younger fractures.
So certainly with the classification which we've now come up with, you mentioned the apex anterior. That is a very definite group of individuals with fractures where the shaft has gone anterior, the head's tilted backwards, and that probably is a much better indication for using your plate and using dual plate fixation. Whereas I think the ideal indication for the strut is the varus fracture, where the medial calcar's gone, and probably in that situation I would err on the side of using the humeral strut or fibular strut, whichever you've got available for that type of fracture if you're going down the surgical route.
And perhaps the best thing about that sort of addition of the apex anterior is the approach then, Mike, as well, isn't it? That kind of gives a lot of, it helps to have the choice of the split or the deltopectoral and using the ideal approach for each of those types of fractures. Is that fair to say?
Yeah, so that's certainly the case. I think definitely the deltopectoral approach does have is the workhorse, and certainly for the apex anterior fractures, it probably gives you better access for putting on the anterior plate as well. Whereas for a lot of the fractures where there's tuberosity involvement, the 3 and 4 part fractures, the split probably gives you better access for tuberosity reconstruction. So it's really tailoring the approach to the fracture configuration there.
And if it's really difficult and you're not sure, then the sabre lets you do both in the same sitting if required.
Yeah, although I have to say I'm using that incision a lot less now, because we operate more for fractures, varus and apex anterior fractures, and in that situation you're using a slightly longer plate, which you can be with the sabre incision in terms of putting in the screws for the lower end of the plate through that type of approach. So probably using the straight split more commonly now.
Excellent. Dimitris, any other comments from the best panel or questions? Just mindful of keeping well to time here.
I don't think there are any other questions, Jamie, no.
No, I don't have any comments to add. And I think it's been a great session, great insights from the Edinburgh team. So thank you very much, guys.
No problem.
Pleasure.
Pleasure. Thanks for the invite.
Thank you.
Cheers.
Excellent. So many thanks to the Edinburgh team for a very stimulating and productive conversation. Some very good learning points there. Just for the participants, your certificates will be sent in the next week. Our next Journal Club meeting will be in May. Exact date to be confirmed soon. And just to remind you that we have the Elbow Update Symposium, which is run by our Exeter colleagues next month. So feel more than free to check that out and register. And thank you all for joining us tonight. Have a good night.